Well, hi, everyone. Welcome to the first of 5 gatherings we'll hold over the next 5 months, celebrating the 40th anniversary of the founding of the Upper Valley Haven. I'm Michael Redmond, the current executive director of the Haven. On behalf of the employees, volunteers, board of directors, thank you for attending today. Today's featured speaker is Bob Drake. His topic is thinking about homelessness from a mental health perspective. More in a bit about Bob. For some housekeeping, our session is being recorded, so folks who are unable to attend today can watch at a more convenient time for them. And due to the size of our audience, as you've noticed, we're using the Zoom webinar format. Everyone's been automatically placed on mute, but Bob welcomes questions and has provided time at the end of his talk to respond to as many as we can. So please write your questions in the chat section, and then we'll take those up at the end of Bob's remarks. As mentioned, we're here today to celebrate the founding of the Upper Valley Haven, its work and role in the community over the past 40 years. On December 8th, 1980, the Upper Valley Haven's board of directors signed articles of incorporation to form a new nonprofit organization. The group included leadership and members of 5 local churches who had been meeting informally since September of that year in pursuit of a common goal, providing temporary shelter in the Upper Valley to those who were in need. By December, they were ready to make it official and, according to the minutes from one of their early meetings, quote, put their faith to work for an emergency shelter. The group decided to purchase the old farmhouse adjacent to the St. Paul's property for $54,000. That's where the current Hickson adult shelter stands, which was built around 2009 and 10. A mortgage was taken out and an angel helped underwrite the down payment and early expenses. The story goes there was a family of feral cats that had taken up residence in the property that had to be lovingly coaxed and fed so they could be relocated. At least that's the official story. Overgrown trees were cut down, the wood sold to fund the purchase of supplies. The Haven opened its doors, its first guests, almost exactly a year after incorporating, December 15th, 1981. Fittingly for the ecumenical organizations, the Haven first live-in couple was named Donna and Corty Church. And they welcomed a family of 7 whose last name was Bishop. Can't make this up. Since those early days, the Haven has grown in the number of staff, the breadth and depth of services, the number of buildings on our campus on Hartford Avenue, and the esteem in which it is held by the Upper Valley community. With these and many other changes have occurred, what has remained consistent is our mission that can be simply stated, no one should be hungry, everyone should have a home. The story about the founding of the Haven was recounted in the first of 40 stories of the Haven that we've been sharing since the beginning of the year about the people, events, ideas, and services fundamental to our mission over those past 40 years. 31 so far and 9 to go. We'll place a link to the series that can be found on our website in the chat, so you can copy that and see that yourself. Turning to our featured speaker, Dr. Robert Drake is Vice President of the Westat Corporation and a retired professor of psychiatry and of health policy and clinical practice at Dartmouth. He has studied psychiatric rehabilitation for 50 years and published nearly 700 books and research articles. Along with Debbie Becker, he developed the individual placement and support model of supported employment, one of the most successful and influential evidence-based practices in rehabilitation internationally. He writes that at the end of a long career, he is thankful for the many wonderful students, colleagues, and clients, including those at the Haven, that he's been privileged to work with over the years. Thank you, Bob, for agreeing to be the first speaker in our series. Welcome to our webinar, and I'll let you take it from here.
Great. Well, thanks very much, Michael and Jennifer and Laura. I really appreciate the opportunity to speak on behalf of the Haven. It's been a great privilege to volunteer at the Haven. I've never worked directly in a homeless setting, but I have been a mental health worker for the last 50 years, always in the public sector. So I've had the opportunity to work with lots of homeless people in North Carolina, Washington, Boston, New Hampshire, and Vermont. And so what I'll try to talk about is the psychiatric or mental health aspects of people who are homeless. And I know from having been a teacher for years that people don't remember data and PowerPoints. So they're much more likely to remember stories. So what I'm going to do today is tell you true stories about three people who have been homeless and have been friends of mine for decades. I've followed them, and I'll tell you about their stories, which I think illustrate the issues about mental health that I want to highlight. And then at the end, I'll summarize some of those issues and leave time for question and answers. So the first of these individuals is named, I'll call Archie. By the way, all of these people live outside of New England, and I've changed a few of the facts, so I don't think we need to worry about protected health information or anything. But anyway, the first person is Archie. Archie was never has never been my patient. I met Archie when I started graduate school down in North Carolina. I went over to the YMCA and volunteered there. And they asked me to coach a little kid's baseball team. They had a bunch of kids from one of the local housing projects that they had collected for, part of the Little League there. And I said I'd be happy to do that. And so I started working with these kids from the housing project. Archie was one of the kids, and he was a standout in several ways. He was a big kid and he had a big ego, and he was full of personality. He wasn't much of a baseball player, but I gather he was a good football player. But in any case, I got to know all these kids, and I loved going over to the housing project, and I got to know their mothers, and I would take them bowling, and we got thrown out of many places together because they were an active group of kids. But my friend Archie was distinctive because he had this wonderful mother. She worked as a maid, but she was very protective and had high aspirations for her son, Archie. And she asked me early on if I would be willing to tutor Archie because she wanted him to succeed in the school. And so I was happy to do that and started tutoring Archie, which went on for many years. And Archie was also distinctive in the sense that he was sort of the king of kids in this housing project. Most of these kids, by the time of sixth grade, were hopelessly estranged from the public school system, but Archie was a pretty good student, and he was considered sort of a hero in the housing project. People expected big things of him. And over time, I was happy to get to know Archie and his mother. She had me over for dinner all the time. She never could understand why I ate salads rather than fried chicken. But in any case, she was a wonderful lady. And over time, I got to know Archie very well. He went on to finish high school, which was much better than most of the other kids there did. He got some kind of small scholarship to a small college to play football, and was relatively successful there. He didn't get any professional football offers as he expected, but he did get a job as a gym teacher and a coach in the local high school, and he was very successful in that role. Married a nice young lady who was a fellow African-American teacher at the school. They had three nice kids together. Archie, though, continued to have these grandiose expectations. Every time I would see him, there was a sort of painful grandiosity to Archie's expectations that he was going to go to the National Football League or be a coach in the college ranks or whatever. And at some point, he discovered that, what really fit with his internal sense of greatness was cocaine. And so he got rapidly addicted to cocaine. A couple of the other kids, I was by this time somewhere else in the country, and a couple of the other kids I knew who had become police officers called me about Archie and said, look, he's going to be in big trouble soon. We know he's really on the circuit with the cocaine trade. And sure enough, pretty soon Archie got arrested, lost his job, lost his family, lost his car, lost his house, and went to jail. And then went to prison, and he was in prison for a while. And when he got out, he had nothing, and he became homeless. And he tried again and again to get jobs as a school teacher or as a coach, but he was pretty much blackmailed from those kinds of jobs in North Carolina because of his record. So at some point, I convinced him to move to a large city where I was working with one of the historically Black colleges. And we had a little research grant, and they hired Archie as a research assistant. He was by this time abstinent and doing pretty well. And he did well in the research assistant job. He continued to be grandiose and was often thinking that he should be running the project rather than the people who were the investigators. But he did an okay job. And then we got another much larger grant at the HBCU, and that allowed them to hire Archie into a higher level position as an interviewer and a part-time clinician in the substance abuse clinic and so on. And he had a really good salary and, had a new car and was rebuilding his life. But he was also getting into conflict with the bosses again because of his grandiosity. He really thought he knew better than they about how to run this project. And at some point, he got into a lot of conflict at work and then relapsed to substance abuse again. And before I knew it, he had lost his job again. And from there, he went back to, using drugs, being homeless, being unable to get a job, and so on. And that went on for some time. And the worst part of it was when he lost this job, he lost his health insurance. So then he lost his access to diabetes medications, and he ended up losing his lower leg. And he was really in bad shape. This is not a happy ending, but what did eventually happen with Archie was that he couldn't get another job that paid so well. But he, through a friend, did get a job working in a retirement home, which is where he is now. In the retirement home, he lives in the retirement home, so it provides housing, it provides food, it provides health insurance, if not much pay. And so at least he's stable at this point. He's trying to rebuild his relationship with his kids and his former wife, but that's a hard task for him. He gets into the same problems with them as he does with everyone else. Others don't seem to share his grandiose view of himself, and he ends up resenting all of us for not helping him enough. So I've known Archie for 50 years, and that's sort of his story. Now, the second person I want to tell you about is a lady who was a patient of mine named Betsy. I met Betsy because she was homeless, and one of the she had been somebody who came from a good family and had health insurance, and or a family with money and had health insurance, had been in and out of private hospitals over the years, had had fancy therapists over the years. None of that had helped her very much, and her family finally gave up supporting her. She ended up on Medicaid, and she was in the public health system and homeless. So when one of the case managers brought her in and asked me if I could work with her, and she was a very interesting young lady. She had what we would now call PTSD and what we called at the time borderline personality disorder. But the real distinctive feature was that she was what we used to call a chronic cutter. That is, she used razor blades to cut first on her wrist and her arms, but then she ended up with cuts all over her body. She had the history, like other people with these kinds of problems, of real abuse as a child. She was apparently, an active, temperamental, acting up, not easy to take care of child, with lots of emotional outbursts. And her mother somehow adopted the strategy of making fun of her when she was upset. So her mother, in a almost sadistic way, would dance around her and sing these songs making fun of her daughter. And Betsy grew up really thinking of herself as an evil person and having this tremendous sense of self-hatred. As an adult, or as a teenager, I guess, she had discovered that as all of this tension and feelings of self-hatred would build up, she could relieve the tension and take control of the pain by cutting herself. Seeing the blood, feeling the pain somehow gave her control over the experience. And this went on, for many years, through many therapies and hospitalizations. She got psychoanalytic treatment, she got CBT, she got dialectical behavior therapy, et cetera, et cetera. And when she became my patient, we tried, my brand of psychotherapy, which wasn't any more effective than the previous ones. And she had also tried many medications over the years. I remember, some of your early patients are the deepest memories. And I remember Betsy well. For one thing, she was the only patient I ever had who came into the office for therapy one day and immediately took off her blouse and pulled out a razor blade and started cutting herself so that she was bleeding all over the place. I had never experienced or anticipated anything like that. And I, put my arm around her and took her over to the emergency room where they spent lots of time sewing her up. I had another experience where she one day came to the office and brought her German Shepherd with her. And she, often got angry with me, as she did with everybody. And when she got angry with me, she had the German Shepherd attack me. That was a unique experience in psychotherapy too. But anyway, I stuck with Betsy over many years, and she, never could quite make it in life. When she would try to get close to people, her emotional volatility would destroy the relationships. When she tried to go to school or tried to work, she would end up exploding at customers or the boss and, lose her job right away. After 3 or 4 years, I was pretty certain that I hadn't helped her at all. And then almost by accident, I ran into an employment specialist who said, well, let me work with Betsy. I think maybe I could find something that would fit her. And what happened is that this employment specialist got Betsy a job working in one of the university laboratories where they were studying cancer, I think. And lots of the animals that were in these studies would die during the day and during the evening. And Betsy would come in during the evening, and her job was to do autopsies on all of these animals. So she would cut them open and she would dissect out each of the organs, and she would weigh the organs and lay them out, with weights and so on. And she would spend all night by herself in the laboratory doing this. It seems like kind of a grisly job, but Betsy loved this job. It really became her sturdy rock in life. She got a good salary. Her people who ran the laboratories loved her work. She was able to get an apartment, take care of herself better, and stop cutting herself. It was almost like a miraculous thing that the job seemed to cure some of her psychopathology, I guess. And as far as I know, that continued for many years after I moved away and lost track of Betsy. And then the third person I want to tell you about was another early patient I had named John. And I met John in the state hospital where he had been for a while, and they were trying to deinstitutionalize people, and everybody thought John was, dangerous and so on, not such an easy person to move into the community. But, John was actually a delightful guy. I remember the first time I met him, we walked around the parking lot outside of the state hospital, and he interpreted the license plate numbers on all the cars to me. They all had some special meaning about the person that drove that particular car. It was really, they were delightful stories. And John himself was an interesting looking character. He dressed in Native American or American Indian garb with beads and tattoos, and his head in a hairband and so on. He was obviously psychotic and, talked to his voices and did a lot of preaching. Well, anyway, I couldn't, even though John had been in the state prison for several years before he came to the hospital, I could see nothing that, he was in prison, by the way, for passing a marijuana cigarette to a state police officer at some concert. And in those days, if you were Black, you could go to state prison, I guess, for such an offense. Well, anyway, there was nothing dangerous at all about John. He was, he was psychotic, and he was manic sometimes, and he was depressed sometimes, and he spent all of his time preaching, but he was really a sweet guy beneath that. Well, when we got John back into the community, we were able to, get him on Medicaid. We got several apartments for him. He would always lose his apartment because he would invite some of the local drug users and dealers into the apartment, and pretty soon it would get known as a drug haven, and he would get ejected from the apartment, and he would end up homeless. So he spent as much time homeless as he spent housed over the years. John was borderline retarded at best, and he couldn't read or write very well, but he became a great advocate for people with mental illness, and he spent most of his time preaching in Cambridge to the public about patients' rights. He and I actually bonded because I helped him every week for a couple of years write letters about patients' rights, which we sent off dutifully to President Carter. And we always expected to get a response from President Carter, but that didn't come in until one day the FBI showed up. What in the heck are you doing sending all these crazy letters to the president? Is this guy dangerous? And so on. And, I reassured them that he was just a good advocate for patients' rights, and they should take the stuff seriously. So we weren't bothered by the FBI anymore, but it was very difficult to see what we were going to do with to help John. When he would take medications, they would block the voices, and he would get very depressed and say to me that his father had stopped talking to his father, being God, had stopped talking to him, and that was a terrible experience. So he really didn't like taking medications. And we finally wore out all of the housing providers in Cambridge too, so we weren't sure where to get this fellow housed. And one of the case managers found a small nursing home outside of Cambridge in outer Boston area that agreed to take John in. This was, by the way, I guess I left out an important part of the study. John had this Indian persona, but he really didn't know whether that was his background. He had been raised in these group homes for people in foster care. And so one of the things he and I did was to try to track down, how did he end up in foster care and in this group home? And, we were able to, get some records and track down a little bit about his identity. He had no American Indian heritage whatsoever. He had an African-American mother who was a prostitute. And when she had babies, she abandoned the babies immediately. And that's how John grew up in foster care for many years. So, John was, even, after finding out about his family, still felt like his only identity was as a mental patient and pursued that. But along this time, when we found this small nursing home outside of Boston, John moved in there. I was totally skeptical about this. I hated putting people with mental illness into nursing homes, but this was a small house with about 10 residents, and we went out there together, and John liked it, and they were very nice to him there, and we thought it was worth a try. And it turned out to be a wonderful place for John. I never would have predicted. The people who ran the place really liked him. They loved his commitment to patients' rights and so on. And then after a few months, the cook there, who was a large Black woman, invited John to go to church with her. And so he started going to church with her and her family. And pretty soon, John and the cook fell in love. And so John would spend, all weekend at their house with the cook and her family, and they all adored John and took him in. And it was just wonderful to see how it transformed this guy's life, rather than wandering the streets homeless, wondering where he came from and what was going to happen to him. He had this loving family that took him in. And I followed John for a couple of decades. He used to get in trouble once in a while with the police, who would take him to the emergency room And, I always gave my patients a card with my phone number on it. I said, if somebody wants to send you to the hospital or to jail or something, please be sure they call me. And so I would get calls once in a while from the emergency department, and some doctor would say, I've got this. I remember this quote. He said, I've got this dirt bag in my emergency room, and he says he knows you. And so, I said, oh, of course, I know John. He's a great guy, and he just needs to get a shot of medicine and he'll calm down. And I would talk to John, and he would go ahead and take the medicine so that he didn't have to get hospitalized. Well, anyway, long story short, John, who seemed to have nothing going for him in life, actually ended up doing very well for at least the last that I heard from him. So those are my three stories. These are all people that I knew for decades while they were in and out of homeless settings and in and out of psychiatric hospitals. And I hope you can see in the stories some of the themes that I'm going to outline now. The first one I want to talk about is what's called the biomedical model. Most people in psychiatry, at least nowadays, believe in this construction that what we see on the surface in terms of symptoms and people's report about their thoughts and their feelings, these syndromes really somehow correspond to underlying psychopathology and genetics, and that for each of these, and we call those illnesses or diseases, even though they don't meet the criteria for illnesses or diseases. And they believe that these illnesses or diseases, are specific, and they have specific treatments in terms of medications. That's just far from the truth. There's no science to show that our syndromes correspond to any underlying psychopathology or correspond specifically to genetics. And there's certainly no evidence that there's specificity of these medications. And this ruse goes on and on. Now you can get your genetics tested, and some people will tell you that that predicts exactly what medication you should be on. And the reality is these medications are not very effective, have as many harms as they have good qualities. And it's sort of trial and error to find the medication that works best for somebody, that they can tolerate and that helps them in some way. If you really follow people over years, like all three of the people that I've described, the diagnoses change, the symptoms change, and so on. And they don't respond terrifically well to any medications or treatment. We do the best we can in psychiatry, but it's not the kind of scientific area that cardiology or liver medicine is. The brain is just way too complicated for us to understand it well enough at this point. Now, while the symptoms change, people's core vulnerabilities, the personality that they develop and grow up with, is pretty constant over time. And there lots of 50-year studies of delinquent kids. I worked on one of them for years while I was in Boston, inner city delinquent kids. And, personalities are pretty constant over time. And I tried to describe here how my friend Archie always had this, malignant grandiosity that made it difficult for him to get along with other people. and how Betsy had this horrible feeling of self-hatred that she could only alleviate by cutting herself and taking control of it. She was ambivalent about the cutting always because it gave her such relief. And it was only an accidental job that helped her out of that. And then my friend John, who spent much of his life in search of a family and an identity as part of a loving family, again, found one by accident. But that vulnerability of his lasted, throughout the 50 or so years that, I've known about him. So those core vulnerabilities, which I think are what contributes to people being unable to, function well in life, those core vulnerabilities are pretty constant over many years. And in fact, when I was doing the longitudinal work in Boston, and we had careful case records on kids starting from 14 into their 60s, I was amazed there too at the persistence of basic personality features. The next thing I want to mention is that social determinants are much more important than treatment. We know from lots of research across many chronic diseases that the course of disease is determined about 80% by these social factors and only 10% by treatment. So, people need secure food. People need secure housing. People need friendships. People need employment and so on. And these are the things that really make a difference in long-term adjustment for people who've got, illnesses and major league vulnerabilities. What you folks do in terms of helping find housing is, similar to employment. I think it's a sort of supported effort to find a housing match and to help people become self-sufficient and take over, the responsibility for themselves. And, in the mental health field, really the most effective intervention that we have is helping people to get a competitive job. Treatment medications don't help people to find good housing. They don't help people to get a good education and so on and so on. But when we notice that when people get employment, they start to have not just an income, but they start to have some self-esteem, and they start to be able to be self-reliant, and they start to be integrated into their community, and they start to have friends who are outside of the mental health system. So, I've come to believe over the years that employment is the most effective mental health intervention that we have. And I'm sure that it's an important part of people getting out of the homelessness situation too, that they have an income and they have a steady job and they have a positive identity. So, I read the other day that the best play of the 20th century was Bertolt Brecht's Mother Courage. And I remember that Mother Courage, who was wandering the hillside, the countryside with her kids during the Second World War, she said, talk to me about morals when I have food and housing for my kids. And I think that's how we should be thinking about people who've got major disabilities and major vulnerabilities in life. Social determinants are first, and more important. Because of all that, I have come to believe that we in mental health should be really modest about treatment. When I was studying the inner city kids in Boston, sort of like the three people that I described to you, I saw many of them who did well in life. And it was usually as a result of the environment that they happened to fall into. I remember one guy who was slightly mentally retarded, but was a hard worker, never really learned to read and write, but he married a nice woman who did the reading and writing for him and helped him start a business where he did kitchen and bathroom tiles. And he was great at doing his tiling job, and his wife took care of him and ran the business for him and so on. And there were lots of examples like that. At the same time, we were looking at the longitudinal studies of Harvard graduates, and we saw lots of these very talented men who would have adverse experiences in adulthood, and their lives would really fall apart. A bad marriage or alcoholism or bad illnesses can really destroy someone's life in adulthood. In the substance abuse field, like mental health, there are many incorrect myths about, treatment and what's helpful. And one of the worst ones is this idea that people need to hit bottom before they're willing to change. Like almost everything I learned in training, that's just wrong. The earlier we can intervene with people, the more likely they are to succeed in substance abuse treatment, in mental health treatment, in employment services, and so on. So when you folks in the homelessness arena get people, many of them have had chronic illnesses and problems for years and years and years. And they come in with these heavy coatings of self-doubt and hopelessness. And I think it's the hardest group to treat of anybody that we see. When we do try to intervene with people who have got, multiple deficits and vulnerabilities, it really needs to be a team effort. I, as a psychiatrist, can't provide good treatment for somebody who's got complex conditions and multiple deficits. But a multidisciplinary team, like we try to put together in great settings like the Haven, can think about people in terms of family and relationships and substance abuse and housing and mental health and food security and daycare for the kids and so on. It really takes a team, if not a village and a community, to be able to, provide good services for people who are highly vulnerable. And even then, I think we rely a lot more than we know on serendipity, that we get somebody into a good situation, or we get somebody into a good job or a good housing environment or a good relationship. And that proves to be the linchpin that helps them turn things around. Okay, I'm gonna stop at this point. I just wanna say thank you again. It's been a privilege to work as a volunteer at the Haven. And you folks who do the frontline work are really my heroes. It's a much harder job than any job I've ever had. I just appreciate so much what you do. And thanks for letting me talk with you today.
Bob, thank you so much for your remarks and story, and it's really a story of your life. So it was generous for you to share that through the stories of others, and agree entirely that's a better way to for people to remember things about the three people that you introduced us to. I invite us, anyone who has questions for Bob, to place those in the chat, and we can, in the time remaining, get more conversation going. Bob, thank you for your, for those who you heard Bob allude to, that Bob serves as a clinical consultant informally to the Haven, meets with our service coordinators here regularly to, as they can present cases and tap into the wisdom that he might have gleaned over the many years that he's been actively working. And Bob, I can see that the underfunding of services at the early age. We've learned a lot in recent years about adverse childhood experiences that have long-term implications for the outcomes that people experience in life, and we heard some of that clearly in the stories that you shared. I think we also heard the the benefits of the social determinants of health, which is where we provide a part of that through the services of the Haven of food and shelter, and many other people on the call who are from a majority are not connected to the Haven, but many are in practice in the work that they do, also providing those kinds of experiences. We've seen the benefit of that, but I think the expertise that you provide provides that extra capacity for us to do the good work that we can. I see there's a question here. Could someone asked, Bob, could you say some more about how to create employment opportunities that can pay a decent wage, provide a healthy work environment, and flex when people with vulnerabilities need support? Perhaps they're asking if you've seen cases where that village comes together, that team effort. Are there any common traits of how people have been able to succeed, maybe not as serendipity as a one-off, but as a unified model of service? Is that been something you've ever experienced?
No. Thanks for asking that, Donald. You may know for the last 30 years, I've been studying supported employment as we've developed supported employment and tried to expand it out around the US and in other countries. The supported employment model, is really common sense, because it takes off on, like most things, when I started studying employment, the experts and the expert professional models of employment turned out to be almost completely ineffective. And when we, my colleague Deborah Becker essentially developed the individual placement and support model by listening carefully to clients and trying to make sure we could provide, what they really wanted. So, people who are unemployed with mental health issues, they want a job that fits who they are and that allows them to succeed, that allows them to make a decent wage, or in many cases, people are on Medicaid, and so they get a payment that's too small to live on, really. But if they work half-time or 30 hours a week, they can keep their Medicaid and they can also keep their salary, and then that becomes a livable wage. And the key to all this, I think, is job matching. Making sure that the job fits the individual rather than is just a job that happens to exist out there. So, the typical employment program will have people work in enclaves, so they get a job for 6 people at the grocery store picking up carts. But, these are people who want to work in the radio business or want to work, in something else. And so the job doesn't really fulfill them at all. But employment specialists are really creative at finding the jobs that do fit them. I remember seeing a guy over in Concord who screamed at his hallucinations all the time. I mean, you know, so he couldn't work in an office, obviously. They got him a job in a sawmill where everybody was wearing, you know, mufflers over their ears, and nobody cared how much he screamed, and he did a great job in the sawmill. I saw a lady in Washington who had wanted, you know, stopped using heroin and wanted to get a job. But, you know, at age 55, she had really never done any work except prostitution and drug sales. But they were able to get her a job drawing blood in hospitals. You know, there are always these patients who come in and they have sclerosed veins everywhere from using drugs, and the blood draw team can't get any blood out of them. They would call this lady and she'd come over and she could find blood on anybody because she'd been doing it for many, many years. And I could give you many more examples, but that sort of job match, you know, that takes advantage. Everybody has some skills and has some interests, and the employment specialists are great at saying, okay, you know, I don't care about your bipolar disorder and your drug use. You know, what I care about is you're really great at taking care of your dog. So let's find you a job working with animals, and especially with dogs, because I think you'd really like that. And then once people get a job, you know, just providing some supports to them, and also some supports to the employer if the client permits, helps them to keep the job over time, and helps the employer to make accommodations and give them a little time off if they, you know, have a relapse. You know, the terrible thing about my friend Archie was, you know, he got fired from a substance abuse treatment job because he never would tell them that he had a substance abuse background. You know, I think they would have given him, you know, a month off to get treatment if he had just been open with them. But we always listen to what clients want in terms of disclosure, in terms of the type of job, in terms of the amount of time, hours they want to work, in terms of what kind of supports they want, and so on. So I'd be happy to send anybody materials on supported employment, or you can go to our website, which is ipsworks.org, and find all the manuals and training videos and so on.
Thank you, Bob. So I'm trying to. So there's someone else posted a question. As a mental health counselor in training, I'm curious about what may be important to focus on to increase my own competency. I heard that belonging, trauma, and addiction may be important to be knowledgeable about. Are there others in your experience that are important for someone starting her career or his career?
Yeah. Well, you know, I have always supervised a lot of residents and psychology interns, and I always tell them, you know, look, the mental health field changes fast. And so what you want to learn in training is how to keep learning. You know, everything I learned in training was obsolete in 10 years, and you could get prosecuted for it in 20 years. It was so out of date, it was considered malpractice. So you have to be able to use the internet and, you know, ongoing training activities. And I really encourage all trainees to be trained as broadly as possible. You know, one of the great things I've always loved about working on teams, you know, I had the lovely experience of starting the first assertive community treatment teams in Boston. And the great thing was you got a group of people with different expertise who are all trying to help the same client. And if you're really paying attention, you sort of learn by watching the person who's a housing expert, and the person who's a substance abuse expert, and the person who's a family therapist. You know, we learn from each other. And I think as a clinician, you know, the more you can understand about, you know, working in the community, and about working, you know, with families, and about working with these environmental and social determinants of health, the better therapist you will be.
Thanks, Bob. I'm wondering if we think that, with a tighter labor market, employers can't be quite as choosy as they might be. It's a challenge, for the opposite challenge in the housing market now because of lack of vacancies and increasing rents. But prior to the pandemic, we saw increases, at least locally, in recovery-friendly workplaces. So
Yeah.
employers recognizing that some people might relapse, but that doesn't make them a bad employee if they're not creating risk to others. And if they can come forward honestly about that they can retain that employee with some additional support. I wonder if you think you're hopeful. I think you're a generally hopeful person, but that there might be a more focus on folks who've had histories of mental illness or other issues that might come to bear now in this tight labor market, where there might be more opportunities for people because employers they can't be quite as choosy.
Sure. We follow about 20,000 people around the country in our supported employment learning community. And in the last quarter, we've seen a big upsurge in employment. I mean, basically anybody who wants to work can find a job right now. You just have to walk down the street and and apply. But what? I did job development for about 4 years, 1 day a week, just so I'd learn about this. And, what I learned is the employers say, look, I hire lots of people that I know are using drugs, and I hire lots of people who don't show up for work, and I don't know what's going on with them, and I don't know if they're coming back or they've quit. Having a relationship with an employment specialist who I can call and say, what's going on, is great. It really helps me to know how to help the person. And, I'm happy the employers are happy to, not happy, but employers are willing to hire people who've had felonies and who've been in prison. And they tell us about, well, this is what I want to hear from the person when they apply for the job. And so that's how we train these clients to go through the interview now. They know exactly what they're going to be asked, and they know what they should say, and they know that it's important to have disclosure and to have employment specialists be involved in the process. So, we haven't had a terrible problem with people, getting fired because of things. Accommodations really make a lot of sense, and the ADA is really helpful to people, but you have to disclose before you walk off the job.
One last question, Bob, was put in the chat. In light of the idea of training and staying current, there is more focus, awareness, it seems these days, on trauma and its impact on individuals, whether experienced as a child, such as Betsy, or later in life experiences like job loss or illness. What connection do you see that trauma has, and do you find the attention and understanding of this being raised could be of benefit in helping those with some vulnerabilities you mentioned possibly heal and just help overall?
Yeah. When I was first in training, people who were difficult or angry or didn't show up for appointments, we called them bad names, which were labeled personality disorders. And I think now we know that, people who have difficulty in interpersonal relationships generally had abusive childhoods, and they had trauma, and they got exposed to alcohol and drugs early. And if we can, there are interventions for trauma now that are effective, and everybody who's a therapist ought to know something about how to use those interventions, just like everybody who's a therapist needs to know about treating alcohol and drug problems. Half of the people with the mental health issue have also got an alcohol and drug issue. It's not, we can't send them to the boutique treatment service. We've all got to be able to help people recover from these problems.
Thank you, Bob. And I'm afraid we've run out of time at our hour, but I really appreciate your being our first speaker in our series of the 40th anniversary. Our long relationship with you at the Haven, I couldn't think of a better person to invite, and really appreciate your taking the time to share your knowledge and life experience with us.
Well, thanks so much.
Yeah, the next speaker in our series is Elizabeth Carpenter Song, a research associate professor in the Department of Anthropology at Dartmouth College. The title of her talk is Moving Towards Security Following Homelessness in Rural New England, Lessons from the Lived Experiences of Families. So another close look at lived experiences. But please join us on October 13th at noon. Registration information can be found on our website. It's also in the chat. And I also see there's a question of accepting volunteers at the Haven. Yes, Lisa and anybody else who asks, please call us and ask to speak to the volunteer coordinator. We would love to have you here in any capacity, because Bob has found a role for us, a role for himself at the Haven that is maybe unique, but we accept everyone because everybody has a talent, as Bob said, and we have found his and we put it to good work. So thank you, Bob. Thank you all for joining us today, and look forward to seeing you again. Bye-bye.
Thanks, Michael.